I would like now to hand over to Dieter to start with the Q&A session. So we have received several questions in the Q&A box. Some of them for the pulmonary artery catheter I have already answered written, and there are still a lot of questions for, especially for the transpulmonary thermal dilution, and Dieter will now moderate these questions.
Yeah, and we will have some quick questions because Xavier has to leave somewhat earlier. So Xavier, one question: how often should TPTD catheter be calibrated, and what is the accuracy of this device during arrhythmias? Can you answer on that, please?
Very good questions. Recalibration. If the last one has been done more than 1 hour ago, doesn't mean you have to recalibrate it every hour in all patients, but I mean that when you come to the patient and you see that the last calibration has been done more than 1 hour ago, it's time to do one other. And in addition, if the arterial tone has changed a lot, when the dose of norepinephrine has changed or the hemodynamic status of the septic patient typically has changed. Regarding the question was regarding the accuracy of
the device during arrhythmias.
Yes, arrhythmias. In fact, there is no problem because transpulmonary thermal dilution, no influence on the accuracy. Regarding pulse control analysis, it remains accurate, but the problem that it's because it's a beat by beat estimation, you see that cardiac output varies a lot. In fact, not that much because it's averaged over 12 seconds, the last 12 seconds. So it means that if patients are tachycardic, you see values that cardiac output that do not change that much. In patients that are arrhythmics and bradycardic, the cardiac output values change from second to second. It's not a lack of accuracy, it's indeed the case in reality because of arrhythmia. Stroke volume changes from beat to beat, you understand, but it's not a problem of reliability.
Okay, thank you for your answer. Maybe one additional question. Can you reliably interpret SVV, PPV values in patients with lung protective ventilation? Do you sacrifice the lung protective ventilation for accurate measurements, and for how long?
No, it's very good question as well. In case of low tidal volume and in case of low lung compliance, meaning in case of ARDS, PPV and SVV have some false negatives. And that's a big issue in practice, and it's a reason why these indices cannot be used in many instances. By the way, it's possible to use PPV, not its absolute value, but the changes induced by a transient increase in tidal volume. It's the tidal volume challenge. I refer our participants to the reviews about this tidal volume challenge. So not the absolute values of PPV, but its changes when increasing tidal volume. I see a question in the chat, open thorax, no, likely false negatives as well.
Xavier, we know that you have to leave. One last question. Two questions relate to the use of transpulmonary thermal dilution catheters in the arteries of the arm, so either the brachial artery or the radial artery. I know that the PICO device has some long radial catheters. Do you have experience with this?
We do. In fact, what is required is that the catheter is free in the diameter of an artery. That's why you need a quite large artery for the tip of the catheter. Basically, it should be introduced with the femoral root, but if impossible, you can use a brachial or even a radial catheter, but then it's long so that the tip is in a large artery. It's reliable, no problem. The only issue is that the patient cannot bend the arm, you know, so the arm must remain straight, which is fully possible during interventions. In the ICU, it's much more difficult, but the brachial access is also possible. And of course, you have less problems with the with artery disease on the brachial artery. So in patients with artery disease, it may be a good option.
Okay. So Xavier, I don't see any more questions for you. So thank you very much for being with us, and we hand now over to the other speakers. It was really nice to have you with us.
I'm very sorry for leaving now. If the participants have some questions, they can send me some questions directly on the chat. Bye-bye, my friends. Ciao.
Hi. Albert, a lot of questions relate to the training problem. So some people argue that the biggest problem with the pulmonary artery catheter remains that people are overwhelmed by the flood of information that they perhaps cannot really interpret correctly, and this can perhaps lead to wrong decisions. So what's your point of view on this?
Yeah, thanks, thanks, Prof. Well, the problem is exactly that. The amount of information that you can get from a full pulmonary artery catheter study is overwhelming, even for, in some settings, for the most experienced of interpreters. So that's why in the literature, and when they talk about it, and specifically this problem, they say it should be coupled to a therapeutic intervention protocol, meaning if you're confronted with a certain situation where you have readings on your pulmonary artery catheter value, then you need something to guide you during that time. This is now for less experienced people who haven't been doing this for many years. So coupling it to an interpretation algorithm to see it, following a path down to make sense of the values is probably the best way to start. And it's been reported in places where there's institutional protocols in place for what to do with the data that you are receiving, low cardiac output, high pulmonary artery pressures, and then just simple diagrams directing you in the right way. That already, a simple intervention like that already leads to better interpretation of the Swan-Ganz catheter. It's mostly overwhelming at one point to try and make sense of everything. So that's a solution to try and improve that.
And I think you agree that we should not blame any monitor for giving us a wealth of information. To remain the boss of this information, the only solution, in my opinion, is training. This, by the way, holds also true for echocardiography. I mean, if you want to use it correctly, you have to undergo proper training, and you have to gather a lot of clinical experience. And this is the same basically for every monitor, in my opinion. But we should not blame the pulmonary artery catheter for giving us a complex picture of a patient.
Absolutely.
Okay, now some questions for André and Matthias. How do you compare brachial artery pressure to femoral artery pressure post-CPB?
Yeah, that's a good question. What we know is that the brachial is better than the radial. So definitively, there are some centers in the States that just use brachial, that don't use radial at all, okay? And they have reported a low complication rate, and they seems to have good data. However, there's very few studies. In fact, I only found one where they compared the brachial and the femoral was better, okay? And that's probably also a diameter issue, also, because if you have a small brachial, it won't be reliable. That's the point. In our experience, I still prefer sometimes, when you induce your patient, it's easier to put a radial or a brachial, but then we will put a femoral. And I could tell you by experience, and eventually I'll have numbers, but probably the gradients are less frequent with a brachial than with a radial, but it's probably around 15–20% that you can still have a gradient. The more severe they are, the more vasopressors they receive, the more you're likely. And the other problem also with the brachial is that it's close to where the surgeon's operating. Often they are compressing the arm, and then in the ICU the patient is moving, then you will lose the signal. So the femoral for us is really the best. The combination is really the best, because if ever you arrive in the ICU and there's no gradient, you just remove the femoral and that's it. And we use a very, very small catheter under ultrasound, exactly like Dr. Monet was mentioning. Like, you look at the anatomy, and if there's any risk, you don't do it. Okay, you don't take any chance. You really want to have a clear view of the anatomy, and you don't want to take any chance. If there's severe atherosclerosis, you don't do it, because you know that 2/3 of the time it's going to be okay. It's going to be okay. You won't have a big gradient, but 1/3 of the time, which is a lot, because if I would try to sell you a monitor and tell you 1/3 of the time it doesn't work, I don't think you would buy it, okay? But it's just something that we've got, that we're seeing. And in fact, it's because it really became an issue because we were seeing those phenomenon initially when I started my practice in every 1/3 of patient. And at the time they were inserted, blindly with potential complications. So at one point we decided to put them ourselves under ultrasound, with much less complication rate.
Andre and Matthias, two other questions. What is your institutional policy? So tomorrow morning you start a case, 75-year-old aortic valve replacement. How do you decide whether you insert a femoral or a radial line? Okay. Or do you do always both lines?
Matthias, do you want to answer? I'll go first.
I think our answer will be quite not the same for this one, because I work in Lyon, and in Lyon we use only radial catheter at first, at the beginning. But if we suspect any gradient during the surgery, we ask the surgeon to put an aortic measurement during the surgery, during the cardiopulmonary bypass, and if there is a gradient, we put a femoral line at the end of the intervention.
So at the Heart Institute, I would say 70% of all my colleagues, they use radial and femoral for every cases, okay? And there's about 30%, and that's how we were able to quantify, the impact of radial versus radial and femoral, that use it mostly just for complex cases. They use the radial and the femoral. The problem with this is that you cannot, I would say, predict who's going to develop or not a gradient. And I would say every day, every week, you see these huge gradients, and patients would say, well, how come I have a gradient? And it's very, very hard to predict. And then often what happens, you go in the OR, you replace your colleague who just put a radial, and then you're on bypass, and then you have to start vasopressin. You start vasopressors that normally you don't start. And it's just because, you read the pressure, it's low, it's 40, 50. You just have to start your vasoactive drugs. And probably this patient doesn't need it, but you won't, you cannot say, oh, I don't believe it. You have to treat the low pressure. So for us, for me, it's routine. It's routine, basically routine, all under ultrasound. If there's any risk, I don't do it under the femoral, but I will put a radial and a femoral in all my cases, and then get rid of it with using a very small catheter, and then get rid of it as soon as the patient arrives in the ICU if there's no gradient.
And then why not always going femoral and leave, not doing a radial?
Well, that's a good point, because again, you can get full. 5% of the time, the femoral will be lower than the radial, okay? And also, it's much more, to do a femoral, you have to drapes, you have to put sterile gloves, you have to prepare the patient. The radial is much more simple to insert. And the radial is reliable until bypass, okay? After bypass, once you start bypass, it's not reliable anymore, okay? And in some cases, it's not even reliable even before bypass. So it's much more simpler. Put asleep, you put the intravenous, the radial, and then once you do the central lines, the patient is asleep, then it takes 5 minutes less, and then you do the femoral, and then you follow your case, and you'll see it. And there's a proverb that says, you only find what you look for, okay? And centers like in Korea, I was presenting there, and they sent their paper in the Canadian Journal of Anesthesia. So they report 2,000 patients, okay? 2,000 patients in which they are routinely use radial and femoral. And what they found using that catheter is about exactly the same number, 34% of gradients as they come off bypass. But probably they underestimated it, because I think that they didn't measure it during bypass. And during bypass, this is 50% of gradient. So it's much, much more frequent during bypass than as you wean. But as you wean from bypass, 1/3 of all your patients will have significant gradients. And sometimes it's impressive. I showed you some numbers. I could show you numbers from every week, like 60 millimeter mercury, 70 millimeter mercury. My colleague mentioned me last week, you're coming up bypass. And then you're doing all these monitoring, these fantastic monitor that you use, but the fundamental monitor that you base all your decision is the arterial pressure. That's the fundamental monitor that you use. And it's not reliable. in the radial. And in fact, when we wrote the paper in the Journal of Thoracic and Cardiovascular Surgery, the editor really asked us to make a strong statement and saying, basically, we do not recommend this. This is not a reliable measure, basically. It's not reliable, not in cardiac surgery patient. And you cannot tell who's going to. It's reliable to do a blood gas, for sure. And if the patient is fine and it's perfectly stable, as long as he's stable, it's fine. But when he becomes unstable, when you need it, it's not fine. It's not reliable. And that is kind of paradoxical, unfortunately.
There are two other questions. One is whether this phenomenon may be related to the length of the catheter. And I would be interested whether it may be related to the transducer. Did you observe it with different transducers as well?
No, because, I'm not sure we use the same transducer in Korea. In Korea, they made the same observations, the same percentage. And the length is a good point because some people have shown that if the longer the catheter you have, for instance, if you use a brachial, the more reliable it's going to be. It's going to be closer to the aortic pressure. So if you have a long brachial, in some centers, that's what they do. They use a very long brachial, so they're close to the larger arteries, and that's probably reliable. That's probably reliable. But there's no studies, unfortunately, comparing this catheter with a femoral artery catheter. So we don't have much data to say, okay, that's better. But for sure, there were some studies showing that the longer your catheter is, and it's probably a matter of diameter. Your catheter will be in a larger diameter artery.
Okay, thank you for these clear answers. For time reasons, we have to abort this Q&A session right now. But don't worry, all the questions that have been asked will be answered by the speakers, and the answers will be posted, will be available at the EACTAIC website soon. So now I want to thank all the speakers for today. It were very interesting lectures. And Steffen and I will prepare some take-home messages, and we also will post them on the EACTAIC website, so you can find our conclusions right there. So now I hand over to Mohamed. Yes, some words to end this session with.
Thanks so much, Dieter. Dear all, I'm very grateful for Leuven University and the Professor Steffen Rex and Dr. Dieter for supporting and conducting this very interesting fellowship seminar, and the first one in 2023. And special thanks to the professors from the talented speakers in the session. A special thanks as well to the organizers behind the scene from AM Group for their terrific work to organize it. And I appreciate your coming. Just a small reminder, few reminders. Please, you'll receive an email including a feedback survey. You have to complete it to claim your certificate for attendance. Also, as Dieter explained, all questions answered and unanswered by the faculty, it will be answered and posted on EACTAIC IC Seminar Fellowship webpage. And then additional to the take-home message. And also here I'm delighted to announce about the upcoming events. We have a webinar next month on March 13, and provided by Pediatric Subcommittee for a Single Ventricle Solution. And we have at March 24 to 25, the second Thoracic Masterclass in Brussels, organized by Erasmus University. It is a physical event and the second one since the pandemic. This is also, I'm delighted to remind you about the upcoming ECHO course in May 2023. Please don't forget to register before the end of BERD registration. Thanks so much for your coming and enjoy your evening.